Good evening. This is Dr. John Bennett, broadcasting from Miami. We have another hangout, Parkinsonism hangout, with Dr. Abdul Rana, a neurologist from Toronto, Canada, and a well-known Parkinsonism educator. Tonight, Dr. Rana is going to talk about corticobasal degeneration and Parkinson's. Good evening, Dr. Rana.
Good evening, Dr. Bennett. How are you?
Very good, very good. Some of these terms you use, I have to figure out what the heck they mean. Okay, I can kind of guess, but okay, I guess we'll find out. Okay, let me start with the first question. How common is corticobasal degeneration?
Corticobasal degeneration is a very rare condition. The exact incidence and the prevalence remains unknown due to several reasons. That it may not be diagnosed as a separate entity, and sometimes it may be confused with Parkinson's disease. About 3 to 5 cases in a 500,000 population, or you can say 0.6 to 0.9 cases per 100,000 as an incidence. The survival rate varies about 6 to 8 years in these patients, and prevalence could be something around 5 to 7 cases per 100,000 population. Okay. This condition was described in 1968 by Rebis, and some of the reports have suggested some genetic predisposition, but it is a sporadic condition.
Okay. What is the usual presentation of corticobasal degeneration?
The age of onset of corticobasal degeneration is between 6th and 7th decade. The patients have a combination of symptoms. They have combination of extrapyramidal and pyramidal symptoms. So most patients would have clumsiness, stiffness, jerkiness, usually involving one limb, right or left limb, and they may have sensory impairment. The patients could have significant rigidity as well as bradykinesia and apraxia of the involved limb. The cognitive dysfunction or intellectual impairment may not be obvious early in the cases, and these patients respond very minimal to levodopa. The most important and a characteristic clinical feature of these patients is the involvement of one side more than the other. So asymmetry of the findings. So these patients would have one arm involved much more than the other, and this asymmetry is maintained throughout the course of the disease in most cases. In case of Parkinson's disease, patients do have a symmetrical presentation. In the beginning, their one side of body would be involved more than the other side, but as Parkinson's disease, idiopathic Parkinson's disease progresses, these patients would lose that asymmetry because of involvement of the other side. In case of corticobasal degeneration, in most cases, this asymmetry of involvement is maintained throughout the course of the disease. And these patients do have sensory impairment. They have limb kinetic apraxia. They also have ideomotor limb apraxia. And this could be noted anytime during the course of the disease in most patients. In a significant number of cases, these patients would have a rigid, dystonic, stiff arm, and the fingers, some of the fingers of the arm would be extended and the others would be forcibly flexed. So this dystonic arm, which is stiff and rigid, it would show jerkiness due to action-induced or a stimulus-induced myoclonus. So if you have this patient and you stimulate their arm with a pen or with a finger tap, so you will see the jerking phenomenon. And sometimes they may have a irregular jerking type of movement, which is quite obvious when you ask these patients to lift their arm or stretch it in front of them. The patients with corticobasal degeneration, they do not have the resting tremor which is seen in Parkinson's disease mostly. If you apply some stimulus to their arm, you would see some distal flexion of their fingers as well. And in addition, as the disease progresses, these patients would develop apraxia, the rigidity, akinesia, and dystonia will get worse, and the myoclonic movements may make their arm functionless. So as the disease progresses, they are not able to use that arm which is involved asymmetrically with the stiffness and the jerkiness. And sometimes these patients may have apraxia in their legs as well. So because of the apraxia in their legs, they have trouble with the gait. So they might have shuffling, they could have a freezing and start hesitation. However, the gait ignition failure, which we see in patients with idiopathic Parkinson's disease, does not happen in these patients. The postural instability and disequilibrium with falls is also noted in these patients, but it happens a bit late in the stage of the disease as compared to progressive supranuclear palsy, in which the postural instability and fall are usually a presenting symptom. With respect to the eye movements could be normal in these patients, especially early in the course of the disease, or they could have abnormal scotic pursuits, increased scotic latency, or difficulty initiating the voluntary scots. So if these patients have early on down gaze palsy, then this is more supportive of progressive supranuclear palsy. And in some cases, the progressive supranuclear palsy could be atypical with some cortical degeneration. The one important feature which can help this to differentiate from progressive supranuclear palsy is the asymmetry of the involvement of the limb or the symptoms. In case of progressive supranuclear palsy, the patients have bradykinesia and rigidity, which is involving both of their sides equally. And these patients in progressive supranuclear palsy, they could seem slow when you check their gait, but their rapid finger movements and hand movements or hand turning could be quite reasonable. So that can help you to differentiate the progressive supranuclear palsy from corticobasal degeneration. Another feature which is seen in almost half of patients with corticobasal degeneration is alien limb phenomena. The alien limb phenomena has been overreported in patients with corticobasal degeneration, although it is not specific for corticobasal degeneration. It could happen in cases of Alzheimer's disease or Creutzfeldt-Jakob disease. In case of alien limb phenomena, patients would describe that their arm does things on their own. So it would move or grab things on its own. So most patients would say that it has a mind of its own. So it would do things without the voluntary participation or intention from the patient. So the caregiver sometimes could describe that when the patients are sitting or they're doing, they're relaxing, so their arm would go in a certain direction and would grab things or do things on its own. So this is a very typical phenomenon, which is usually reported by history, less commonly seen in case of physical examination, but it could help to differentiate from a progressive supranuclear palsy. In case of corticobasal degeneration, these patients have sensory extinction, astereognosis, agraphesthesia, as well as impaired two-point discrimination. There are signs of corticospinal tract involvement, such as extensor prompt responses or Babinski signs, usually on both sides. They might have hyperactive deep tendon reflexes. They could have bulbar dysfunction, and visual inattention. These patients may have a frontal release signs, such as the grasp sign, and dysarthria could develop in these patients, usually a bit late in the course of the disease. And these patients may have dysphagia, which could lead to a swallowing problem and aspiration pneumonia, which remains the main cause of the morbidity and mortality in these patients. With respect to cognitive dysfunction in these patients, they usually have the frontal executive dysfunction. These patients would have dementia involving the limited attention or concentration. They do have executive dysfunction, behavioral changes, urinary incontinence, and bilateral motor signs such as Parkinsonism, as well as pyramidal sign in combination.
Okay. Does imaging help to show some findings, Dr. Rana?
Imaging could help to a certain degree, although not every patient would have findings on MRI. In some cases, or in advanced stage, patients could show asymmetrical cortical atrophy, especially in the pericentral area. This can be seen in a significant number of patients, especially as the disease progresses. On the FLAIR images, there could be some hyperintensities involving the atrophic cortex, as well as the subcortical area or the underlying white matter. On T2 weighted images, there could be hyperintensities of putamen as well as globus pallidus in these patients.
Okay, very good. That wraps it up for part one. Is there anything else you'd like to say about corticobasal degeneration in Parkinson's? Anything else?
I think the most critical feature, one of the most critical feature, which may help a beginner to differentiate this from progressive supranuclear palsy, is asymmetry of findings, which is usually maintained throughout the course of disease, and that could serve as a clue. In case of idiopathic Parkinson disease, having the pyramidal signs could help a person to differentiate from idiopathic Parkinson disease. With respect to the dystonic stiff arm, although there have been no reports about the relation of sidedness, in our experience at our center with the corticobasal degeneration, we had noted that the dystonia of the arm is more on the non-dominant side as compared to dominant side. However, we have seen only a small number of cases, up to 20 or so. So you can't draw any definite conclusions from this, but it should be kept in mind, and further research or studies could be done looking at the relationship of the dominant hand and the dystonia of the arm in patients with corticobasal degeneration.
Okay, that wraps it up for part one of corticobasal degeneration and Parkinson's. We'll see you in part two, Doc.
Thank you very much, Dr. Bennett.
Okay.